a $9.8 billion government backstop for Medicare Part D just ended. It paid out $6.2 billion in 2025 and another $3.6 billion in 2026 to hold standalone drug plan premiums down. And on July 29, 2026, Medicare confirmed it will not run again in 2027. If you are one of the more than 50 million Americans with a prescription drug plan, you are probably asking one of two questions. Is my premium about to double? Are my medications about to get dropped? So let me put the first real number on the table. The base beneficiary premium moves from $38.99 in 2026 to $41.33 in 2027. That is $2.34 a month. And that is not the number that is going to hurt you. Almost every article about this ends the same way. Nobody knows what you will pay until your plan letter arrives in September. I think that is a cop-out. We already have the variables sitting in public documents. We have the new $41.33 base. We have the out-of-pocket ceiling moving from $2,100 this year to $2,400 next year. We have the list of drugs with negotiated Medicare prices, and we have the 2.8% cost of living raise on your Social Security check. 4 inputs, and that is enough to calculate your own personal inflation rate for 2027 before a single letter shows up in your mailbox. I have watched people open that letter in October, feel the panic, and switch plans over a weekend based on the premium line alone. That decision then costs them money every month for the following year, and by the time they see it, they are locked in. So I am going to walk you through the 3-step math to model your own worst case, starting with the exact mechanism that just broke. If you are between 55 and 65 and trying to work out whether your retirement budget survives a jump in healthcare costs, hit subscribe. We do the math so you are not guessing. Start with what that $2.34 increase actually represents. The base beneficiary premium is the anchor Medicare uses to build every standalone drug plan premium in the country. It moves from $38.99 in 2026 to $41.33 in 2027. And it moved because the premium stabilization program is finished. Here is what that program did, because almost nobody explains it. In 2025, it knocked $15 per member per month off the premium side, and it capped how much any standalone plan could raise your premium year over year at $35 a month. For 2026, it was scaled back to a $10 reduction and a $50 cap. It was a shock absorber bolted between what a plan actually cost and what showed up on your bill. The absorber is gone. The road did not get any smoother. So why did insurers need an absorber at all? Because of the hard ceiling on your drug spending. A few years ago, there was no dollar limit on what a bad year could cost you. Now you stop at $2,100 in 2026 and $2,400 in 2027, and above that, the plan and the drug manufacturer carry the rest. That was the right change for households. It also shifted a large slice of catastrophic drug cost off the government's books and onto the plan's books, and somebody was always going to pay for that. For 2 years, the subsidy volunteered. The insurers have already told us what they think it costs. Every year, each one submits a bid, which is its own estimate of what covering the basic drug benefit really takes. For 2027, the national average bid came in at $296.05 a month, roughly 24% above the prior year. Your base premium is going up about 6%. Look at the gap between those two numbers. When a plan's stated cost rises several times faster than the premium anchor, that difference does not evaporate. It gets recovered somewhere else, in the deductible, in which tier your drug sits on, or in the plan quietly not existing next year. That last one is already underway. In 2024, there were 709 standalone drug plans nationwide. In 2025, there were 464. For 2026, the count is 360. That is roughly half the market gone in 2 years, and the plans that survived did not survive by being generous, which means the trade you are making next fall is mostly invisible. If you choose your plan on the premium number alone, you are locking in a drug list you have not read, and you find out in June at the pharmacy counter, when you cannot switch again until the next open enrollment. A $2.34 change in a base premium is not the risk here. Being stuck with the wrong formulary for 12 months is the risk, and that is the part moving quietly while everyone stares at the premium, the formulary shuffle. I used to tell people to wait for the annual notice of change in September and deal with it then. I was wrong about that. Waiting made sense when premiums moved $1 or $2 and the plan list was stable. With the subsidy gone and half the plans gone with it, waiting means reacting. Modeling it now means planning, and the whole exercise takes about 20 minutes at the kitchen table. Step 1. Pull up your drug list and mark which ones carry a negotiated Medicare price. The first 10 negotiated prices took effect in January 2026, and they cover prescriptions that are extremely common in this age group: Eliquis, Jardiance, Xarelto, Januvia, Farxiga, Entresto. Another 15 drugs join that list in January 2027. This matters because a negotiated price puts a ceiling on the price the plan is working from, and your share is calculated off that lower number. If your medication is on either list, your downside is smaller than the headlines suggest. Step 2. Apply the ceiling and keep it in the right bucket. The $2,400 limit in 2027 applies to what you spend on covered drugs. It does not touch your premium at all. Those are two separate lines in your budget, and people blur them together, then wonder why the cap did not protect them from a bill that was never covered by it. Step 3. Put your Social Security raise next to the result. The cost of living adjustment for 2026 was 2.8%, and your Part B premium of $202.90 a month already comes out of that same check before it ever reaches your bank account. Now watch how that plays out with a real set of numbers. Say Robert is 64, takes Eliquis plus 2 generics, and pays $42 a month for a standalone drug plan. In 2026, his premium runs $504 for the year, and his drug spending lands around $1,900. Call it $2,404 out the door. Run 2027 without the shock absorber. Suppose his plan takes the premium to $62 a month, which it is now free to do, since the $50 increase cap died with the demonstration. That is $744 for the year. Say a rough quarter pushes his drug spending to the full $2,400 ceiling. His total becomes $3,144. The difference is $740 across the year. On a $2,000 monthly benefit, a 2.8% raise is about $56 a month, or $672 for the year. His entire raise is gone, and he is still $68 behind before he has bought a single bag of groceries. That $740 is his personal inflation rate. It is not a national average, and it does not belong to anyone else. You can run the same thing on the back of an envelope in a few minutes. The honest version usually lands lower than the worst case, because most people never reach the drug ceiling at all. That is fine. The point is to know the range you are living inside, instead of waiting for someone to hand it to you. There is one assumption in Robert's math that can break the whole thing. He assumed Eliqui stays on his plan's preferred tier. If the plan moves it to a non-preferred tier for 2027, his monthly copay can triple overnight. The $2,400 ceiling still holds, but it stops being a limit he never touches and becomes a bill he is guaranteed to pay in full. And the money leaves his account early in the year, in large chunks, which is a very different problem from spreading it out over 12 months. That tier decision sits on page 40 of a document almost nobody opens, which is exactly why the next trap works so well. As standalone drug premiums climb, Medicare Advantage is going to look better and better, because a lot of those plans carry a $0 premium and fold the drug coverage in. That comparison is going to be sitting in your mailbox right next to the letter telling you your current plan is going up. Run both paths honestly. The fragile path is the switch you make to save $20 a month. That is $240 a year, real money, and I am not going to pretend otherwise. What you traded for it is the network. Your cardiologist of 9 years may not be in it. The imaging center you have used since your first scare may not be in it. You find that out on the day you actually need care, which is the worst possible day to be reading a provider directory. The durable path is keeping a Medigap policy alongside a standalone drug plan, absorbing the $41.33 base and whatever your plan adds on top of it, and keeping every doctor in the country who accepts Medicare. You pay more each month for something you cannot see, which is exactly why it feels like waste right up until the year it is not. Now the part that rarely gets said out loud. Leaving Medigap is easy, coming back is not. Outside a few specific windows and a handful of states, an insurer can look at your health history and either raise your price or turn you down. So the $240 you save this year can quietly cost you the option of returning it all. And you will not discover that until the year your health changes and you go looking for the door you walked out of. We have watched this happen before. Between 2008 and 2010, Medicare Advantage plans pulled out of a lot of rural counties. People who had dropped their supplement to chase a $0 premium found their plan gone and no clean way back to the coverage they used to have. Nobody set out to trap them. The incentives simply pointed everyone in the same direction at the same time, and the people with the least room to maneuver absorbed it. If both options are genuinely open to you, this is a real decision with a real trade-off, and it deserves an afternoon with a pen, not a snap judgment at the mailbox. Then there is a group that does not get to weigh any of this, because the choice gets made on their behalf. That is where the damage tends to land hardest. If you receive extra help, the low-income subsidy that covers your drug plan premium, your plan has to stay at or below a regional benchmark to qualify. When a plan exits the market or bids above that benchmark, Medicare does not leave you without coverage. It assigns you to a different plan automatically and notifies you by letter. That sounds like a safety net, and in one narrow sense it is. You keep coverage. What you do not keep is your drug list. The replacement plan can carry a $0 premium and a completely different formulary, and nothing in that automatic assignment checks whether your specific medications are on it. Here is the version I have seen play out. A brand name inhaler sits on Tier 2 with the old plan at a $10 copay. In the new plan, it is on Tier 3, or it requires step therapy first, and the copay is $95. Same person, same lungs, same prescription, nearly 10 times the cost. Insulin is protected at $35 a month regardless of which plan you land in, so that one is safe. Very little else is. The scale of this is what people miss. Standalone plans fell from 464 in 2025 to 360 in 2026. Fewer plans in the market means fewer plans priced under the benchmark, which means more reassignments and fewer places to land. If you are on extra help, you are the most likely person in the system to be moved, and the least able to absorb a bad landing. The move that protects you is small, and it is free. Before October 15th, find out whether your current plan is still a benchmark plan in your region for the coming year. Your plan can tell you, and so can the State Health Insurance Assistance Program where you live. If the answer is no, you pick your own replacement during open enrollment, and you check your medications against its list before you enroll. If you wait, the system picks for you in late autumn, and you spend January on the phone arguing for an exception, while you ration an inhaler. The automatic assignment is not the villain in this story. It is a default built to guarantee coverage, not to protect your particular cabinet of medications. Defaults only turn dangerous when nobody reads them, which raises the obvious question: why do so many of us pick the wrong plan, even when the information is sitting right there in front of us? That part has nothing to do with Medicare. We are wired to price the thing we see every month and to discount the thing we only pay when we are sick. The premium is visible, predictable, and it hits the same day every month. The copay is scattered and occasional and easy to forget, so the brain files the premium as the price of the plan, when it is really just the entry fee. It is completely normal to feel angry when a $30 premium becomes $45. That is a 50% jump on a fixed income, and it lands like a tax nobody voted on. I understand that reaction, and I have had it myself. But sit with the arithmetic for a second. Say the $45 plan covers your $600 medication for a $10 copay, while the cheaper $30 plan puts that same drug on a coinsurance tier where you pay 25%. That is $150 a month instead of $10. You saved $15 on the premium and handed back $140 at the pharmacy counter. The cheap plan is the expensive plan, and it will stay that way for the whole year. The fix is a single habit change. When you compare plans, stop sorting by lowest premium. Enter every drug and every dosage you actually take, and sort by lowest total annual cost instead. That math already gets calculated for you on Medicare.gov. Most people never look at it, because the premium column is the one that feels like a price. There is also one perfectly legal move that sits entirely outside the Medicare system, and it is the reason some people pay less for a prescription than their own drug plan charges them for it. It comes with a string attached, and you need to understand both halves before you use it. Step 1. Audit the cabinet. Write down every prescription, the dosage, and how often you fill it. Not from memory. Pull the bottles out and read the labels, including the ones you only refill twice a year. This list is the input for everything else, and one wrong dosage on it can throw your annual estimate off by hundreds of dollars. Step 2. Check the cash price. Ask your pharmacist what a drug costs without insurance, or look up a discount cash price before you fill it. For a fair number of generics, that cash price is lower than the co-pay your own plan charges you, and when that happens, paying cash is simply the cheaper move. The string attached is this: money you spend outside the plan does not count toward your $2,400 out-of-pocket ceiling, so use cash on the cheap generics and run the expensive drugs through the plan, where you want every dollar counting toward that ceiling. Step 3. The September 30th rule. Your annual notice of change is supposed to be in your hands by then. If it has not arrived, call your plan or your agent and get it. Do not spend October guessing while the better plans fill up around you. Do those 3 things and you walk into open enrollment with a number in your hand instead of a feeling in your stomach. This is bigger than a drug plan, though. Every dollar of it comes out of the same Social Security check, and that is worth sitting with for a minute. So here is where we actually stand. The $9.8 billion stabilization program is over. The base premium moves to $41.33 for 2027, and the national average bid jumped 24%, which tells you plans will be looking for that difference somewhere. Your drug spending still stops at $2,400. Your Social Security check went up 2.8%. Those are facts you can line up on one page and work with. What you cannot control is the headline. Between now and the end of the year, you are going to see a lot of numbers designed to make you anxious. And most of them describe a national average that belongs to nobody in particular. Your number is your drug list, your plan's tiers, and your premium. Nothing else. You have handled harder things than this. You raised kids, you paid off houses, you got through 2008 and everything that came after it. A $2.34 base increase and a letter from an insurance company are not going to be the thing that undoes your retirement. What undoes retirements is deciding in a hurry with incomplete information, and you are no longer working with incomplete information. Do the audit, run both scenarios, and sort by total cost instead of premium. Subscribe to Wes Investor, and I will come back with the update when the final 2027 plan ratings are released in October.